All right, everybody, welcome back for the final session in our JA track this morning for the Arthritis Foundation's Live Yes Showcase. Again, if you haven't been here all day, my name is Melanie and I'm your moderator today. I'd like to thank our sponsors, Horizon Therapeutics and Columbus Medical Research Foundation, for their support of today's programming. There are some housekeeping notes in the chat. We are recording our session. We will save Q&A for the end if we have time. If not, shoot questions to us via email. And we will be ending this session promptly at 12:30 so that we can get back over to the wrap-up plenary session with the larger team. Now let me introduce Stacy Arduin, who is going to introduce our speaker today.
Okay, well, welcome back to those of you who've been with us before, and welcome to anybody who's joining anew. My name is Stacy Arduin. I'm a rheumatologist here in Columbus at Nationwide Children's Hospital. I'm very happy to introduce our next speaker, who's going to talk about involvement of the jaw in arthritis, which is a really important problem that we face from the provider and family perspective. Our speaker is Dr. Marinka Twilt. She's an assistant professor and she directs the clinical research operations in rheumatology for Alberta Children's Research Hospital in Calgary, Canada. She's also been very active in the organization we've discussed this morning called CARA, or the Childhood Arthritis in Rheumatology Research Alliance, where she is a leader in a work group that focuses on TMJ involvement in arthritis. So thanks for joining us, Marinka.
Thank you for having me, and thank you for allowing me to talk about the most important joint in your body, the TMJ. So if we can go to the next slide. So the TMJ really is sort of like a jawbreaker, I think, for all of us, not only for the providers, but also for the families. It's really a difficult joint. If we go to the next slide. I do have a couple of conflicts of interest. I'm not a radiologist, although I will show some radiological features. I'm not an orthodontist, and I'm also not an oral maxillofacial surgeon, but I'll do my best to talk about those treatment options as well. Next slide. So the TMJ actually was already described as being involved in juvenile arthritis in 1890, so a long time ago, and also by Still, where Still's disease comes from in 1897. And in the 1980s and then later, there were lots more of interest in the TMJ and much more studies that were going on. And now if you would like combine the two terms, TMJ arthritis and JIA, on our PubMed, which is where all our scientific publications are, you find more than 5,000 hits. Next slide. Why is the TMJ so important and so strange compared to other joints? One joint cannot function without the other joint, so it's not like a hip. If you move one hip, that the other hip can stay still. Both have to move at the same time. And then you have your condyle, your fossa, and in between there's a disc. And it all needs to work really smoothly to give you the mouth opening and the function that you need. Next slide. What is so unique? Well, the mechanical loading is higher than in any other joint to be able to eat your steak or to chew gum, which nobody should do. And it's also one of the most overused joints in our body, and it's used more than 2,000 times a day, like I'm talking here, or maybe people are yawning while I'm talking. If we go to the next slide. The other thing that is very unique in the TMJ is that the growth center for the development of the jaw lies exactly under that condylar hat that we saw in the picture. And it's very close to the inflamed synovium. And for that, it also is very vulnerable to inflammation, but there's also regeneration that has been described. So it's not, if it is destructed, there's never any regeneration possible. If we go to the next slide. Who is affected? As was alluded to already, a lot of patients unfortunately have some kind of like involvement of their jaw or in their disease at one point. The numbers, as you see, 17 to 87% spreads really widely, and that has more to do with how you diagnose TMJ arthritis, and we'll come back to that a little later. All subtypes of JIA can be affected, so it's not if you are an oligo with just one knee, you're free from developing TMJ arthritis compared to somebody who has like a 16 effective joints when they present with JIA. Most children or adults do not complain about any symptoms of TMJ arthritis, so they're asymptomatic. And by the time symptoms do appear, usually there is already some associated damage that we can find. If we go to the next slide. So what growth disturbances do we see in TMJ arthritis? Next slide. If you have it on both sides, then you get what used to be called a bird face appearance. So it really is the sort of like the chin moving backwards towards sort of like the neck area. And on the right side, you see the asymmetry that appears if you have like just one job that is affected. And that really has to do with the fact that because of that growth center being so vulnerable, the side that is affected does actually not grow as much as the other side. Next slide. So what do we do as clinical examination? So first we do inspection. If we go to the next slide. Oh, here the pictures are not visible for some reason. Oh. So micrognathia, so that's the first picture. That is what we call that bird face. It's either retrognathia, which means, you know, the gnathis is the mouth. It's like positioned backwards. And as you can see on the lower picture also, we can see frontal facial asymmetry with mouth closed. So you see normally when you would put a line through your face, your midline in your forehead, your nose, and through your mouth has to end exactly at the point of your chin. And you can see that in this patient, it's deviated because there's asymmetry. Next slide. Oh, I have put apparently some animation in here. Asymmetry here, you can see it as well on open mouth examination there. So if you open your mouth, there is an asymmetric opening. Sometimes what happens is that people have what we call an S-shape opening. So that means it opens, it deviates a little bit, but when they're maximum opening, they're actually quite symmetric again. And that has just to do with that disc being a little bit obstructive when you open your mouth, and it's nothing to worry about. Next slide. There is like a group that looked at like what kind of clinical orofacial exam should we do in JIA, they have brought out some recommendation, and we can go quickly over the next slides, just click through them. And it just is like here, it's medical history and orofacial symptoms. Next slide. The clinical examination should be palpation of the TMJ. Next slide. Also the function, so maximum mouth opening. Next slide. And also symmetry as we just described. Next slide. So what kind of measurements do we take during the, so the first measurement we do is maximum mouth opening. And if you go to the next slide, so you measure the mouth opening, and then it's either with a ruler, or if you click one more time, it's with a called a therabite, and both work really well. It's a little bit depending what you can do. A ruler needs to be sterilized the whole time in clinic, which might be difficult for your provider. And a therabite is just a little cardboard that you can either take home, or it's been thrown away after your visit. And here in millimeters, they measure your mouth opening. If you go to the next slide. Maximum mouth opening is like not one time that you can say, oh, it's abnormal. You really have to do it multiple times. And it also, during life growth, it changes. So if we go to the next slide, you'll see there's actually a growth chart for mouth opening. This is done in Switzerland, where they have that all the kids go to a school dental bus, and they measured all the mouth openings of all the kids in the school. And you see that this is for boys, because boys have a little bit of a bigger mouth opening than girls. So boys go from like 30 millimeters minimal to 46 when they're young, and then they go up to sort of like 40 to 66 millimeters when they're older. The next slide is a girl, and as you can see, the beginning is sort of like the same, but they end up to 60 millimeters, so they don't open as much as a boy. Next slide. The other thing we do is palpation. So you really palpate. If you do the next, take one more time on the slide, you'll have a picture probably. Oh, let's go back. So what you do is you really put your fingers here, and you can feel yourself one tenderness, and then you can also feel what is called like, so it's like snow, crepitus, bono, and then translation. What is translation? So if you open your jaw, you have that condyle and you have the fossa, and if you open it, there's first a rotation, and you can feel that if you would put your fingers there, and then you have a translation, which is sort of like the moving forward, and you should be able to feel that in your own mouth opening. Next slide. Another thing is like the clicks and the crepitus. So some people will use like a stethoscope on it. To be honest, clicks can be sometimes even heard by the provider in the room, and usually it can be very well described by the one who has the crack. Next slide. Just to remember that, clinical symptoms are rare and they're also unreliable. A lot of people have clicks and it doesn't mean anything. Pain, if you have pain, it usually is absent in young children when we examine them. And sometimes it's only present in sort of like 15 to 20% of the patients. Function is a little bit more reliable. So if you really have a restricted mouth opening or an impaired translation, that usually is associated with some involvement of the TMJ, which sometimes can be either arthritis or it can be muscle related. If we go to the next slide. So how do we diagnose TMJ arthritis? So that's really done by imaging. And if we go to the next slide, there's a couple of imaging methods that we have. So cephalograms are just an X-ray of your face. Orthopotomogram is something you usually do at the dentist office. So it's sort of like that picture that they make and they see all your teeth on one X-ray. And then a cone beam CT is a CT, but really specifically only of the face. And these methods are good for bony changes. You can see the bone really well, but it doesn't show any of the synovial, so the inflammation. So it doesn't really help us to say, is it at this moment actively involved in your JIA, or is it something that happened in the past and it's already not active anymore, and then it doesn't really need any treatment. If we go to the next slide, another option would be ultrasound, and we do a lot of ultrasounds in other joints. The problem with the TMJ is that it's a little difficult to see the joint with ultrasound, just where it is positioned. And then it does show acute inflammation, and it also shows chronic bony changes. So we would think if you can do it, it's great, but it's so independent of who does the ultrasound for this joint that if you don't have a lot of experience or you don't have the same person the whole time, it's really hard to get the same results. And at this moment, really to examine the TMJ, the gold standard is MRI with contrast, which shows inflammation, it shows bony change, it can show disease progression over time, but unfortunately it's quite costly, it's lengthy, most of the time it takes an hour, and if you're really young, it means that you need to be sedated because there's no way you would stay still in one position for an hour. Next slide. What do we look for in the MRI? So as I said, we sort of look for acute changes, which is, the same in other joints like the synovial fluid and synovial thickening, which, in a knee, you can also see fluid sort of like outside because usually your knee's swollen. That doesn't happen in the TMJ because of where it's positioned. So we really need the MRI to show that. And then chronic changes is more like the bony changes. And as you saw in that first picture, the condyle is really nice and round. And if you have inflammation, it sort of like becomes flat. And that's a sign that there has been inflammation or is inflammation as well. If we go to the next slide. So what about braces? Because a lot of children go through an episode of braces. So next slide. There has been a study that has been performed to see, and there is a little bit of effect from braces. It depends a little bit what kind of MRI they do. Stainless steel brackets interfere the most. So if you need braces, ask for ceramic. And Invisalign is now, of course, one of the top choices. And that actually is great because you can just take it out when you need your MRI. So that's not a problem. Can we go to the next slide, please? What about treatment for TMJ arthritis? Next slide. So just like other joints, there's the local treatments, the systemic treatments, and then there are some mechanical treatments that are quite specifically for the TMJ. So if we go to the next slide. So the first one I'll describe is corticosteroid injections. So next slide. So corticosteroid injections, intra-articular injections, you sometimes get in a knee or in another joint. In the TMJ, it also relieves pain as it does in other joints. It sometimes also settles the acute inflammation. And most patients, if you would give them a corticosteroid injection, would have an improved mouth opening after injection. However, as you can see on the next slide, there are some disadvantages as well, which is that usually it only is very short-lived. It doesn't stop any progression of the bony changes or the chronic changes. And there's even, where first it was only studies in mice or rabbits, but now there's quite some evidence as well that it actually interferes more with the growth of the mandible, the growth of the jaw, if you have had injections than if you have systemic treatment. Next slide. There are some complications that we also see with other joints. So one is skin atrophy. So that's that little dimple you see just in front of the ear. And then some calcifications in the joint, which you can see on that cone beam CT there. If we go to the next slide. We have had a little bit of a paradigm shift over the last decade, probably, because we used to inject a lot of patients for TMJ arthritis, but now the thought is more that if you're skeletally immature, so if you haven't reached your final height yet and you're still growing, it's not recommended to routinely inject with corticosteroids. If you're skeletally mature, so if you're already done with growing, then it may be an indication to use corticosteroid intra-articular injection. Next slide. Other treatment options, so if we go to the next slide, is systemic treatments. Next slide. It has taken a long time before we actually had people do a real examination on, like, you know, what happens if you give systemic treatment with the TMJ. And as you can see on the next slide, this is a group in Switzerland. It was only 38 patients. They were sort of like 9 years when they started this study, and they did serial MRIs, and they treated them with biologics or DMARDs, depending on what the provider thought was the best medication. And then they looked at the mandibular growth in the group that had TMJ involvement from the start or developed TMJ involvement, and the group that never had any MRI abnormalities. And the mandibular growth rate was actually almost the same in those two groups. So the systemic treatment did not influence the growth rate as we had seen with the steroid, intra-articular steroids. So the conclusion was that systemic treatment actually decreased the degree of inflammation really well, and it also maintains normal growth. Next slide. Next slide. Another one is sort of mechanical, so splinting. Next slide. As you know, you can get splinting for your arms, for instance, for your wrist as well, but this is orthopedic splint treatment for the mouth. So they looked at, like, what if you have that one side involved and you become asymmetric, if they would give you what is called a distraction splint, would that help or not? And they did find that actually it reduces that asymmetry, so it does help with not getting more asymmetric, or even like maybe helping with resolving the asymmetry. And if you go to the next slide. They also looked at, like, orofacial symptoms, because a lot of patients do develop at one point orofacial pain or function abnormalities. And this is what is called a stabilization splint. So as you can see, you can barely see it, like when you look frontal to patients. And it's really sort of like used to make your teeth an ice rink. So you can't really find that bite. And instead of like biting on your teeth, you're sort of like relaxing because you can't find that. And that really helps for orofacial symptoms. If you can go to the next slide, and then the next slide immediately. Other treatment options, so next slide is physiotherapy. Next slide, you really need to have a physiotherapist who knows what to do, because it is manipulation of, like, the neck and face area. Next slide. And we know that sometimes our patients also have, or your child has, like, neck involvement, and then these motions have to be really under good guidance. So make sure that your physiotherapy is aware of, like, what JIA is and what TMJ involvement is. Next slide. Then surgery. So if we go to the next slide. So if you have an end-stage deformity, you don't need surgery. It only needs surgery if there's functional impairment. So your MRI can look the most worst in the world. If it doesn't change any function and you have no problem with the way your face looks, surgery is not needed. It really is only needed if you don't have good function. And then there's sort of like 4 surgeries that can be done, and I won't go into too much detail because it's not my area of expertise, but one is called orthognathic surgery, one is distraction osteogenesis, and one is TMJ reconstruction, which is sort of like in 2 parts. So if you go to the next one, orthognathic surgery is really that you sort of like move both the mandible and the maxilla. So both parts, the upper and the lower jaw, are moved in surgery. So it's quite invasive. If you go to the next slide, distraction just means that it means that they sort of like cut your mandible, so your lower jaw, and then they move it a little bit apart, and then they leave it like that, of course, like with a stabilizer, and then they hope that new growth of bone will happen, and then it will help with like moving that mandible forward. If you go to the next slide. TMJ reconstruction can be in 2 ways. It can be with a bone of yourself. So this is a rib that they use for to sort of like make a new mandible, like a new condyle, or it can be done, as you can see in the next slide, with like a sort of like a fake joint. So if we go to the next slide. So this is like something that has been developed sort of like to help people. What if you're like, you know, when do you choose what? When can you use what? And this helps more the provider with like sort of like thinking when should they send you to a surgeon, when might be a good time to do some splinting. Next slide. So what about outcome of the TMJ? Next slide. So TMJ arthritis can develop later in the course as well. So long-term course, it doesn't mean if you don't have it when you get your arthritis that you won't develop it. And that it can improve over time. So that's what we call regeneration, so improvement. And then improvement usually is if you have lower overall disease activity. That's why it's so important to make sure that the JIA completely is under control. And if you have a better mouth opening capacity, that is also usually associated with better improvement. Next slide. We do have to consider there's a couple of long-term studies out there that say that there's still a lot of like damage, and at the end they're 27-year-old like follow-up periods. But we have to remember that's pre-biologic era. That's before we had our our medications that we have now. And at the moment in clinic, we see less and less severe that micrognathia, that like reduced chin movement. And we also see a decline in maxillofacial surgery. So the medications do help with like preventing the TMJ being severely affected. Next slide. And I think that's it, to give some opportunity for some questions, I think.
So we do surgery?
Wow, that was awesome. Thank you so much, Marinka. Does anybody have any questions about this fast and furious TMJ conversation?